Welcome. We have John Bilezikian is going to be our first speaker. And I'm going to moderate between your guys' questions and everybody online. We'll kind of go back and forth. So please come up to the mic if you have a question. You can interrupt the speakers, as Dr. Lewicki said. And John Bilezikian, who many of you know very, very well, is going to give us an update on anabolic treatment.
And thank you, Lynn and Mike. And again, I really wish I were with you. I've been to the Santa Fe Bone Symposium every year for 15 years. I was there at the first one, and I look forward to the 25th anniversary meeting next year. Unfortunately, I can't be with you in person, but I am here. So today we're going to review and update us all on clinical aspects and uses of the osteoanabolic agents. These are my disclosures. So let us start by the basic point. What are we trying to do when we treat individuals who have osteoporosis? What we are trying to do is to improve their skeletal health. And that has a lot to do with not only bone density, but also skeletal microstructure. And as you can see in this slide, one of these goals is to improve that bottom panel that is severely osteoporotic to the middle panel, which is less osteoporotic. And this used to be a dream, it probably still is, but ultimately, it may be possible in the years to come to completely restore skeletal microstructure. There are 3 osteoanabolic agents available now that are attempting to reach that goal. And as you know, they are teriparatide, abaloparatide, and romosozumab. These drugs are used in individuals who are at high or at very high risk. And there are many organizations that have offered definitions of what we mean when we say high risk or very high risk. Almost by definition, anyone who's going to be treated for osteoporosis is at high risk. The T-score of less than minus 2.5 was actually established in part because the prospective risk of a fracture in someone whose T-score is less than minus 2.5 over a 30-year period is very significant, like about 50%. We all know that a prior hip or vertebral fracture defines half risk, and we know by FRAX that one of the cut points of 20% for any major osteoporotic fracture or 3% for a hip fracture. These are, by definition, high risk. Very high risk adds to this list those who have T-score and fragility fractures, those who have even a lower T-score or a fracture within 12 months. Some of us believe that if you've had a fracture while on approved therapy, you suddenly become at very high risk. Multiple vertebral fractures, severe vertebral fractures, and a FRAX score that is actually higher than that earlier threshold of greater than 30% for any fracture or 4.5% for a hip fracture. And we're becoming more and more aware of the bottom point. High fall risk is really important. It is true that even if we have severe osteoporosis by any of these other criteria, we're not going to break our hip unless we fall. That's probably true in 95% of the cases. So high risk or very high risk patients, many of these individuals will meet one or more of these guidelines. We shouldn't forget the anti-resorptive drugs because these drugs, many of them are extremely effective. We use them and they are approved for individuals at high risk. So we have both the anti-resorptives and the osteoanabolics. And I think we would all agree despite the fact that there are some risks, the benefits in most cases outweigh those risks. But you want to assess the benefit risk ratio, obviously, for any one of your patients individually. So let's return now to the concept of an osteoanabolic agent. This is a kind of the idea that the agent stimulates bone formation forever and ever. But I would say be careful what you wish for, because you don't want bone to be formed forever and ever. We know the disease sclerosis is not a good disease. So that is sort of theoretical, but not exactly desirable. So let us go back to the beginning and talk about that ironic observation that began the whole field of anabolic therapy. And that irony was the appreciation that a drug that we all knew as a hormone to be catabolic and bad for bones. And it is parathyroid hormone. So it is. We know parathyroid hormone is bad for bones. I've spent most of my career trying to make this point, whether individuals have severe hyperparathyroidism or even not severe hyperparathyroidism. In the context of the disease, parathyroid hormone is bad for bones. And I love to show this picture. You've all seen it. It gives us an insight into the devastating potential of parathyroid hormone to destroy the skeleton. Captain Charles Martel on the left, you see him in two versions, one as a very healthy sailor, and on the right you see a few years later what hyperparathyroidism can do. On the right, these are skeletal radiographs of a patient I took care of years ago, illustrating the classic radiographic features. In the upper left, the salt and pepper degranulation of the skull. On the upper right, the distal clavicle you can't even see. The lower left, there's subperiosteal bone resorption. And in the lower right, this is a woman whose bones are literally riddled with osteitis fibrosis cystica. Now, I point that out, not because we never see it, but we don't see it as much now as we used to. Much more often, we see the disease, hyperparathyroidism, presenting as a relatively asymptomatic disorder. Nevertheless, we and others have shown that even in this more modern presentation of hyperparathyroidism, it can be bad for bones. So we now want to make a conceptual leap from PTH as a bad actor when present in excess to PTH as a therapeutic for osteoporosis. And the seminal observation we usually attribute to Harold Dobnik about how many years ago, 1997, where he showed the dual action of PTH when presented continuously in relatively high dose, that would be hyperpara, you have a catabolic effect. But when given daily in low dose, it is anabolic. Now, Bob Marcus will remember and correct me that it wasn't Harold Dobnik who first showed this, but actually Fuller Albright and Hans Selway in the 30s actually appreciated the anabolic potential of PTH, which is hard to imagine because in those days, PTH was considered to be bad. I want to redefine what I mean by PTH for the rest of the talk. Parathyroid hormone is a 1 to 84 amino acid peptide. We do use PTH 1 to 84, but not for osteoporosis. Rather, we use the 1 to 34 foreshortened version, which is fully biologically active, at least as far as the classical actions of parathyroid hormone. And there are analogs to teriparatide that feature this amino acid terminal end of the molecule. Again, just in the way of background, now 20, how many years ago, Bob Neer showed using a single small 20 microgram dose, and he also used 40 micrograms, that in a double-blind study, that this dose, 20 micrograms, which is what we use now, reduced new vertebral fractures and non-vertebral fractures in a highly significant manner. And David Dempster was one of the first to show that not only did it reduce fractures, but if you looked at skeletal microstructure by bone biopsy, and now we have more sophisticated ways of looking at skeletal microstructure, you can see how impressive this effect of PTH is, not only in terms of the trabecular compartment, but, and this is interesting, but also in terms of the cortical compartment, which in another form, that is in hyperparathyroidism, we see the cortex of bone to be more vulnerable. But in using PTH as a therapeutic, we see improvements in both of the cortical and trabecular compartments. In summary, major clinical trials with teriparatide have confirmed its utility and effectiveness in those with mild or severe osteoporosis with more than one fragility fracture. It's been shown to be effective in glucocorticoid-induced osteoporosis. And we and others, including Eric Orwell, have shown that it is effective in men with osteoporosis. So let's take a step back and think about what we mean by these osteoanabolics. How are they leading to a rebalancing of bone in which bone formation is favored over bone resorption? There are three different ways you can think about this. This is thanks to David Dempster, whose concepts have helped drive this field in this way. One way you can form bone is to take advantage of that scalloped bone resorption unit, and as it is being replaced by new collagen, there is a more exuberant effect so as to overfill this resorption cavity. So this would be an example of bone formation on a previously remodeled surface. In the middle is a different way of forming bone, and we think of this more in the growing skeleton, but it has also been shown in adults, not only with teriparatide, but with other drugs, that you can form bone on quiescent surfaces with no evidence of previous bone remodeling. And again, it's appreciated now that adults do have a capacity to form bone on quiescent surfaces. And then in the lower cartoon, taking advantage of the filling and overfilling of the bone remodeling unit, there can be even a greater effect so as to spill over into the quiescent area of bone and thus have bone formation on both remodeling surfaces as well as on quiescent surfaces. So these are the thoughts about how bone can be formed. And with regard to teriparatide, most of the evidence favors this affecting bone formation in terms of remodeling in the top cartoon and overflow remodeling in the bottom cartoon. There's not a lot of evidence that teriparatide is a direct modeling agent. Going back to this cartoon, I showed it to you earlier where the increase in bone formation is maintained forever. We are careful about what we wish for. We really don't want that, nor does the body want that. So these anabolics, doesn't matter what the FDA says or what you say, these anabolics have a limited biological life. And everybody's different. I've had people on teriparatide whose bone turnover markers start to fall after 1 year. I've seen a lot individuals whose bone markers fall after the 2nd year. And in the old days, when we used teriparatide, and now we're beginning more and more to think about more than 2 years of therapy, you will eventually see a downturn in bone metabolism. And this is, again, not anything to do with rules of the game, but more the biological constraints that the body itself puts upon how much bone we're going to form with these osteoanabolics. I have taken the blame, or maybe the credit, I think probably both, for thinking about these actions in 2 ways. First being a marked increase in bone formation. And if you look carefully at most of the data, you will find that there's an interesting delay in the effect of these drugs to compensate, that is, by limiting bone formation, by increasing bone resorption. And there is a difference in time between bone formation and bone resorption. And that difference in time gives the body an opportunity to build bone. You can call that an anabolic window. And you can think about ways in which you might be able to widen that anabolic window. So safety of PTH. It was first approved with a boxed warning because of the oncogenic effect of the drug given in very high doses for a very long period of time in rats. 2 years is a long time in a rat. That there was a 50% incidence of osteosarcoma. As some of us way back when, and Bob Marcus will remember, that
a bit of
hello, somebody is okay. We didn't think then, and we don't think now, that osteosarcoma is a human toxicity, and that box warning is now removed, or has been removed for several years by the FDA. Nevertheless, we need to be cautious in those who are at risk for osteosarcoma. So that 2-year proscription has been removed, and so we use our judgment. And I would go back to bone turnover markers as to how long we might want to use these agents, with a downturn in these bone turnover markers helping to indicate to us that it might be time to transition. So with teriparatide, we have more bone formation than bone resorption. And if you want to give teriparatide a score, you give it 2 pluses. Now, abaloparatide, very interesting drug. It is an analog of PTHrP, which is an analog of teriparatide. PTHrP is found in normal people, and in certain situations it becomes a predominant hormone, particularly in the developing fetus. In the green, comparing the long green sequence of teriparatide against PTHrP, the green cassettes here are areas of homology. So a lot of PTHrP is not like teriparatide. Abaloparatide is really interesting because out to residue 22, it is identical to PTHrP. And thereafter, in more the carboxy terminal end of the 1 to 34 peptide, in these yellow cassettes are where there are a few amino acid substitutions that give abaloparatide different effects on bone. The different effects were sort of empirically settled on, and abaloparatide fell out of this high volume throughput study, thinking about an analog that would bind more selectively to one of two configurations of the PTH-PTHRP receptor. The RG configuration is the one that is thought to link more effectively into the anabolic pathways of the cell. So if you compare abaloperitide and teriparatide in this regard, and look at the RG conformation, which is the more anabolic one, you won't see much of a difference in terms of binding of these ligands to the receptor. But if you look at the R0, which is the non-anabolic conformation, you see that abaloperitide has much less affinity than does teriparatide. So looking at this as a ratio, you're going to think that abaloperitide would favor RG, therefore be more anabolic. And that's the hypothesis. Let me just touch on it a little bit more. Here's the RG on the left, R0 on the right. The RG is a sort of a micro or nano second interaction with the PTH-PTHRP receptor, and it generates a spike of one of its second messengers. On the other hand, the R0 conformation leads to a more prolonged cyclic AMP signal. A more prolonged cyclic AMP signal is not good when you're looking for an anabolic effect. So on the left, we want a quick hit and to trigger anabolic effects. And on the right, which is something I'll talk about tomorrow, you don't want that. You want, when we're treating patients with hypoparathyroidism, you would like to generate a more prolonged signal and favor the R0 conformation. So this is the idea that we want to push this system more into the RG configuration. And looking at the top here, abaloperitide seems to have better binding to RG, lesser binding to R0, while teriparatide seems to have equivalent binding to these two conformations. So there does seem to be some evidence that the signal generated by abaloperitide may be more conducive to an anabolic effect. So the likely mechanisms of anabolic action may also include modeling-based bone formation. There is some evidence with abaloperitide, but it's still basically, we're talking about remodeling-based bone formation or overflow remodeling-based bone formation with both of these peptides. So you all know about the clinical trial. Paul Miller, hi Paul, was the first author of this very important paper that gave the results of the phase 3 clinical trial of abalo. The placebo and abaloperitide arms were double-blinded. Teriparatide arm was open label. Comparing abalo with teriparatide in terms of bone density on the left, they were more or less equivalent and much greater changing bone density than placebo. And in terms of new vertebral fractures, both abaloperitide and teriparatide were very effective. Bone density changes similarly, although there might be some tendency for abaloperitide to increase bone density in the hip regions a bit faster and a bit more than teriparatide. There also is some evidence that abaloperitide may begin to affect non-vertebral fractures much earlier in the therapeutic course, as you see in the arrow, as compared to teriparatide, which is actually not different from placebo until you get to about a year. And at that point, you see a differentiation between teriparatide and placebo. So abaloperitide may lead to an earlier effect to reduce non-vertebral fractures. The active study had an open label extension. Both the placebo and abalo arms were continued. Both arms are now alendronate. The teriparatide arm was stopped after that first 18 months. And the data actually are very interesting because beyond that 18 months, when both arms were on alendronate, you see this difference is maintained. That early effect of abaloparatide is maintained even over the 2-year extension when both groups got alendronate. Active and active extend showed reductions in the first 18 months of new vertebral fractures. In that second period in the middle of this slide, also a significant reduction, and taken all together, a 43-month period, there was a major reduction in new vertebral fractures in the group that got initially got abaloparatide. Non-vertebral fractures after 18 months were also clearly different in the group that got abaloparatide initially. In summary, with abaloparatide going to alendronate or placebo going to alendronate, there are major differences favoring abaloparatide in terms of vertebral fractures, non-vertebral fractures, all clinical fractures, and maybe most and major osteoporotic fractures. There's a consistency of effect here. The drug seems to be equally effective in the older groups, younger groups, diabetes, those with CKD. Throughout these different groups or cohorts, there aren't many differences or any differences in terms of effect. So the abaloparatide kinetics, if you look at bone turnover markers compared to teriparatide, they're interesting. In both teriparatide and abaloparatide, you have a quick hit on terms of bone formation as measured by P1NP. In terms of bone resorption, and we talked about this anabolic window, there is a delayed effect to increase CTX. It may be more delayed with abaloparatide and certainly not as great in comparison to teriparatide. So if you want to go back to this cartoon, you may not agree with me, but this anabolic window shown here for teriparatide with similar effects on bone formation with both of these ligands, but different effects on bone resorption, abaloparatide not having as great effect, you could argue that abaloparatide is giving a wider period for bone formation. Comparing Forteo or teriparatide with abaloparatide, there are a few little differences. Abaloparatide doesn't have to be refrigerated after it's first used. They're both daily injectables. Abalo is 80 micrograms, Forteo is 20 micrograms. The limits of use have been changed with the branded product, and those who are still at high risk after 2 years, you can choose to continue. Abaloparatide still has that 2-year restriction. The anabolic window, I suggest, is a bit wider with abaloparatide. I haven't talked about the adverse event profile, but they're not that different. Some people think there might be a more of a cardiovascular effect. These drugs are vasodilators, so they can cause palpitations, they can alter blood pressure, they can alter heart rate, but not really problematic except in a small number of people. And concerns of osteosarcoma, except for those at risk, we have relegated that to not a big issue. So abaloparatide.
John, I'm going to interrupt you because everyone's listening intently, but I don't see any questions coming in from all of you remote. And I want you guys to start standing and asking questions. So I'm going to interrupt and ask a question because this is what we want to do. We want it to be really interactive. And I know you might get to this and you're in the middle of your talk, but what do you think about going more than 2 years? And, if you can share that with us, since the osteosarcoma warnings, not as thought to be as much of a concern. And anyway, just a question to get people thinking about coming up to the mic and asking questions and interrupting.
Yeah, thank you. Thank you, Lynn. Yeah, very good. Very good question. And there's no problem with interrupting. We want these presentations to be, obviously, we prepared, but we want there to be good interaction. So I'm glad you asked that question, because this 2-year issue, now not legislated by the FDA, was based on, this safety concern. Again, my opinion and others didn't share the FDA's opinion. But I think much more important is how these anabolics are affecting bone. And as I indicated before, without rules or recipes, eventually, whether you use teriparatide or abaloparatide, eventually the drugs are not going to be anabolic. Their effect on bone metabolism is going to be controlled. Bone doesn't want to build itself forever. And I would say that tracking the effect, bone density isn't good for this purpose. But if you track bone turnover markers with either of these peptides, they will not stay up. They will eventually come down. And not everyone is going to show a downturn at 2 years, or some even at 1 year, but maybe not until 3 years. So I would track the effect of these drugs by bone markers, which many of you know I use a lot, as an index of their biological effectiveness. Thanks, Lynn. Okay, so here's this table we're filling out, teriparatide versus abaloparatide. I gave them both big arrows for formation, a smaller arrow for abaloparatide affecting bone resorption, and thus I gave an extra plus for abalo in terms of the ratio of bone formation to bone resorption. So romosozumab, that is the other osteoanabolic that's available now. And we all know about romosozumab and the sclerostin Wnt signaling pathway, how sclerostin acts as a brake. When sclerostin is not engaged with these transcription factors, Wnt as another transcription factor will engage with LRP 4, 5, and 6, which then gets beta-catenin to relocate from the cytoplasm to the nucleus. And that then triggers the anabolic effect of the cell. All systems should have controls. Biology has to have controls. And this anabolic pathway is no different. Sclerostin being that control, it engaging also with these membrane-bound factors, and then preventing Wnt from uncontrolled anabolic effect. And you then get beta-catenin being metabolized in the cytoplasm, and thus with limited entry into the nucleus. So this is the normal situation. Now, with regard to an anti-sclerostin or romosozumab, what you have is sclerostin being engaged with the antibody, and this then allows Wnt more easy access to LRP 4, 5, and 6, and then you get a facilitated transport of beta-catenin from the cytoplasm to the nucleus. So the anti-sclerostin is releasing the brake, the biological brake of sclerostin, and allowing Wnt to be more effective.
So John, this is Lynn again. We have 2 questions here that I'm going to interrupt you to John, Bob Marcus.
I'm not hearing anybody.
Okay, go ahead, Bob. Before we do a remote question, go ahead and ask your question. We're getting it all set up here. And I thank you for everybody remote with your questions. We will get to yours too.
John, that was one of your best talks. It still is one of your best talks. I was struck by a recent table that you showed about the doses, because the molecular weights of abalo and teriparatide are not so different, yet what is used for Forteo or teriparatide is 20 micrograms, and what's used for Abalo is 80 micrograms. Using more than 20 for teriparatide didn't seem to do much more except increase side effects. So I'm wondering, fourfold, how are you thinking in terms of potency on that? And before you answer that, I just want to say that I was always had some concerns about your views on the anabolic window, but I think your views on that have matured so much that I completely accept what you're saying about it now.
Well, Bob, this is wonderful. If I were there, I would give you a big hug. Well, I think the anabolic window concept is, it's like any concept. It should be tested. And time sometimes makes it more secure or less secure. But thank you for being more sympathetic to this concept. Now, getting back to the dosing, yeah, I don't know. I wasn't there when when the dosing was set. And speaking to your point, these are drugs, these PTHs have other effects. They're cardioactive. We were one of the first to show that PTHRP, and now Abalo can have major effects on cardiac function in terms of contractility and chronotropy. Also, they can have effects on peripheral vasomotor effects. So the point of 80 mics versus 20 is important when you think about the effects of these drugs on the vasculature. And that may be one reason why I have seen, and many others have seen, abaloparatide having a greater unwanted, if you will, to use that word, effect on these aspects of metabolism. But I don't know why 80 was chosen. I can't go back to the phase 2 trials to elucidate them.
Thank you. We'll take one more in-person question, then we'll wait to the end. But just that, we have 10 questions now. So this is perfect. Go ahead.
Hi, John. This is Bent Langdal from Denmark.
Oh,
I just have a question. We're not allowed to use teriparatide for more than 2 years in Europe still. But I was just wondering if there's any experience with retreatment. So you talked about how long should you continue what I assume would be the first treatment, but what about retreatment? Do we see the same anabolic response if the patient has been off teriparatide and on an anti-resorptive for years and then try retreatment? Is that a possibility?
Yeah, Benty, thank you very much. And good to have you at the Santa Fe Bone Symposium. I wish I were there. Yeah, so Europe, there is a limit. Yeah, there have been a few studies. Felicia Kosman did a similar study where she used teriparatide for 2 years. And then, as I remember, she had a period of time where there was no treatment. I don't remember, it was a year or two. And then she retreated with teriparatide. Bob, you may remember this better than I, but as I remember, the second treatment after a period of no treatment was associated with a similar effect on bone markers and bone density. So there wasn't a desensitization on that period of retreatment. Bob, am I remembering this correctly?
That was a yes. And there are seats. Please come down and find seats for those in the back. We will continue. Thank you all.
Okay, shall we go ahead, Lynn?
Yes, please do.
Okay, so the romosozumab clinical trial, again, we're familiar with. Felicia Kosman published the major study in the New England Journal, and you all know the very nicely designed study using Romo, 210 milligrams sub-Q monthly versus placebo monthly with a transition to DMAB. The reason why it's a 1-year drug is because it's a 1-year drug. The drug does not have much of an effect after the first year. So this was programmed to be a transition from Romo to DMAB or placebo to DMAB. And you see the endpoints of the study. And impressively, I'm always amazed by this whenever I see this slide, a 13.3% gain in lumbar spine bone density after 12 months. And you'll see it's reproduced in another study. A major increase, of course, the hip never increases bone density to the extent as does the lumbar spine, which has to do with the fact that the lumbar spine is metabolically much more active because it's more enriched in trabecular bone than is the hip region. But nevertheless, the total hip and the femoral neck show pretty impressive gains, 6.8%, 5.2% over the first year. And then the transition to denosumab gives you a little bit of a little bit of an improvement over the first year of Romo. In terms of non-vertebral and symptomatic clinical fractures, the curves begin to separate at 6 months, and you can see significantly different by 1 year Romo compared to placebo. So this was the ARCH study. That was a head-to-head comparison between romosozumab and alendronate. Again, a 12-month study followed by denosumab. And again, the question was, how would romosozumab fare when in a direct comparison with alendronate after the first year, and then with that background, the transition to alendronate for year 2. And you can see again with the red arrows in this other study, Romo again increased lumbar spine bone density by over 13% with a slight further gain with alendronate over the next 2 years. Again, total hip shows the same that I showed you before. And curiously, and we'll touch on this a bit more, you see on the lower left-hand panel, a major, and quick stimulation of bone formation as seen by P1NP. Curiously, if you hadn't measured P1NP until 12 months after you started, you would have missed that tremendous anabolic kick that is associated with Romo, but transiently. Also notice that there is the expected decline in P1NP if you compare it to alendronate. So here are the data, the head-to-head showing blue being Romo, pink being alendronate, fracture risk through year 2 on the left, markedly reduced with Romo versus alendronate, and on the right, also, but perhaps not as dramatically, you see further differences in the Romo arm in terms of clinical, non-vertebral, and hip fracture. Now, this is a study that gives support to the idea that this sclerostin antibody is actually permitting or facilitating bone modeling. And you see this tetracycline label on the animal study on the top and the human study on the bottom. You see a tremendous amount of bone formation, literally covering the entire surface of bone, arguing that this drug is, at least in part, initially a modeling-based drug. From a microarchitectural point of view, on the left, you can see the trabecular compartment grossly looking better. And on the right, you see the actual data with BV over TV, trabecular thickness being significantly different from placebo, with maybe an effect on cortical thickness, but not significant. So in terms of Romo, most of us are thinking that this is initially and primarily a modeling-based drug, which is interesting because we didn't think before that humans had the capacity to grow bone on quiescent surfaces. Now, another aspect of Romo, and I just touched on, and this is the animal study, that looked at boxed the anti-resorptive effect of the sclerostin antibody. Looking in this overrectomized model, it seemed to be reduced from the sham control, suggesting, but not truly appreciated until later, that this drug has another effect, which is to reduce bone resorption. And this, if you can see that first data point, there's about a 50% reduction almost immediately. Then there's a little bit of a recovery. I'll try to show this. And then it goes back down to about 50%. And this is very reproducible, that rapid 50% drop, a little bit of a recovery, and a further level of 50% reduced. And again, look at the left. Again, this burst of bone formation as seen by P1NP, but after 12 months, there is no longer evidence, at least by P1NP, that the drug is an anabolic. So you've got a dual action agent initially, and then over time, and we don't use the drug for more than 12 months, but by 12 months, it basically has become an anti-resorptive. So again, Bob, forgive me for going back to this cartoon, but let me suggest that with romosozumab, what you're doing is adding to that anabolic window by reducing bone resorption. And again, let me compare that to what teriparatide does, which, as you know well, works very differently by ultimately stimulating bone resorption and thus narrowing that anabolic window. Now, safety. This has been a huge discussion, and I'm not going to enlighten anybody on this, but we need to know about the cardiovascular safety data. And there are two studies, the two beautifully controlled studies, the FRAME study, which was placebo-controlled, and the ARCH study that was head-to-head with alendronate. The placebo-controlled study in the black font, if you look at MACE effects, major cardiac effects, all of them, MI, stroke, cardiovascular, all put together, there were no numerical differences, either when they were all taken together or when they were individually assessed. The hazard ratio crossed 1, not significant. On the other hand, comparing Romo against alendronate in the ARCH trial, you see a numerical imbalance for all MACE effects and individually for the individual MACE effect, with the hazard ratio now 1.87 and the confidence interval doesn't cross 1. So arguing that these are significant imbalances. And why? We can discuss this in the Q&A period. I would love to hear your thoughts about why there are differences between these two very well-controlled trials. Recently published just a few months ago in a real-world setting, again, take that for what I just said, comparing romosozumab with parathyroid hormone analogs. This was a propensity score matched cohort study looking at MACE events after 1 year, fairly large number of individuals in each group. And if you can look at this next to last bullet, Romo versus PTH cohorts, there were fewer MI and cardiovascular events in the group that got Romo versus parathyroid hormone. So this paper concluded that in a diverse real-world setting, romosozumab is associated with fewer adverse cardiovascular events when compared to PTH analog therapy. So it's not clear what we're dealing with, but we need to try to gain greater insight as we go along. So this table now I filled in with Romo. Again, a nice anabolic agent. It does reduce bone resorption. And if you want to look at this ratio, you might give romosozumab another plus on the ratio of formation to resorption. Now, we do have a few minutes, Lynn, and I'd like to touch on the horizon of anabolics. And there are two I would like to call your attention to. These are oral formulations of parathyroid hormone. And the first is from a company called Entera Bio. It doesn't have a name, or if it does a name, I don't remember it, but we call it EB613. And even more on the drawing board is a capsule made by Rani Therapeutics. So this EB613 is a very interesting oral PTH, and you can see that the concentration after oral administration of 2.5 milligrams, it really spikes, and much greater than the subcutaneous, that is the spike, much greater than what you see with teriparatide when 20 micrograms are administered subcutaneously. On the left, there's a dose response in terms of the concentration of parathyroid hormone in the blood as a function of the dose of EB613. And in the middle, you can see at the different doses of EB613, a progressive increase in P1NP after 1 month. And on the right, very early at 6-month data, arguing that this oral PTH is also increasing lumbar spine bone density. Looking at some of these markers with EB613, you have, again, this difference between changing bone formation, P1NP, and reducing bone resorption so as to have this difference that might explain an anabolic effect. Again, the companion placebo study did not show that a window. The increases in bone density were not appreciably or different in the lumbar spine, but looking at the femoral neck and the total hip when it was compared historically, this was not head-to-head, historically, EB613 seemed to have an effect, let's say an effect, on bone density of the hip regions, while the lumbar spine wasn't so evident. Here is the safety profile of this drug that's in development. And again, as you would expect, a lot of these effects are what you would expect of a parathyroid hormone as a vasodilator, the headache, the nausea, the dizziness, palpitations are part of what we see when we use these PTH analogs. Now, very interesting, this oral PTH shows a difference in bone turnover. I'm showing the bottom 3 panels. This is teriparatide daily, and you see the usual increase in P1NP and the delayed and lesser increase in CTX. Now, weekly teriparatide, this is from the Japanese, and they showed years ago that there is a reduction in CTX and a more modest increase. Now, this was weekly, 56.5 micrograms subcutaneously weekly, which, by the way, was associated with a lot of GI side effects. Nevertheless, you see a downturn in CTX in this administration. And with this newer oral teriparatide, EB613, it looks like weekly. You've got this little blip of significance of P1NP that dissipates, and from the get-go, you have a reduction in CTX. So I think the oral PTH is behaving differently from daily sub-Q, and I'd like to get Bob's thoughts about this. Just wondering whether oral teriparatide has got to get through the liver, and I wonder whether teriparatide is getting chopped up. And we know that if you knock off the first or second or third amino acid of PTH 1 to 34, you get an inhibitor. Is this oral teriparatide generating other peptides that are limiting or inhibiting resorption. So it's a hypothesis that I'm interested in, and I'd like to get your thoughts about it. Now, finally, there's another oral formulation that is really interesting. This is called the Rani pill. It is a capsule that, that has anything you want to put in, growth hormone, any peptide. And the idea is to deliver biologics that don't make it by themselves through the GI tract, to protect them until they get to a site in the small bowel where they can be absorbed. So the Rani pill contains PTH 1 to 34. It's said to have bioavailability even greater than sub-Q injection. There is a lot of developmental work that has to be done, but so far it seems to have promise. This was a phase 1 study, a single site study in Australia, comparing Forteo and 2 different doses of the Rani pill. And these comparison of adverse effects, there really wasn't much to see there. But very interestingly, if you look at parathyroid hormone availability, of course, the control would be Forteo, and you see the typical spike and then the downturn over a couple of hours. But this Rani pill, at the higher dose with the purple triangles, and at the lower dose of the blue, you see an uptake that's pretty robust. But I'm curious about this long tail. And it's also long when you come to the lower dose. And we who have thought that PTH requires a quick hit and then a quick dissipation might wonder about whether this Rani pill is going to behave in the same manner as would be and is the way sub-Q PTH would be. It remains to be seen whether that's going to be the case. Now, the company, this is all very early data, claim that the configuration of uptake is not too different from Tymlos. And I'm not sure about this. I'm just presenting it to you. I think a lot more work has to be done. So here we are with another oral PTH, and we'll have to, see how this comes along as this drug is further developed. So let me end here, and I'm glad we have time for a Q&A. My conclusions are that osteoanabolic agents have emerged as key approaches to help restore skeletal microstructure. We have 3 anabolic agents that clearly show advantages over anti-resorptives in terms of one of our therapeutic goals, which is to improve skeletal microstructure. And I'm very intrigued by these approaches to the oral administration of PTH as perhaps a very attractive way of administering a drug. And finally, I would say that osteoanabolic agents should be considered as first line in patients who meet guidelines of high or very high risk, as I indicated before, and if there are no safety concerns. So my last slide, next to last, you see these 2 very well-known ball players. You'll notice that they play for the Boston Red Sox. And I want to thank one of these ball players, Mike, for 24 years of this great symposium. And then in closing, I can't forget Elliot Schwartz, who was a mainstay of Santa Fe Bone for so many years, always sitting in the front row, and always asking questions and always being engaged. And I always think of Elliot when I think of the Santa Fe Bone Symposium and how much we miss you. So thank you very much. I'll be happy to, I'll stop share and I'll be happy to answer any questions.
Thank you, John. Fantastic. We'll start with Bob Marcus, and then I'm going to
Good.
go back and forth with some remote questions as well.
I think, John, your proposal about perhaps having hepatic degradation of PTH is certainly highly reasonable and could be easily tested. I mean, I think you'd have to go to some old-fashioned techniques like high-pressure liquid chromatography to identify what the peptides are actually in the circulation at the time. I would ask the same question about that pill. If the pill does what you say, it increases absorption through the gut, then the liver will also be playing, and you should have the same phenomenon taking place. And the half-life seen with that pill is of concern because, as you know, 1 to 84 PTH is not nearly as anabolic as 1 to 34. And if you're really, what are they measuring there? It says PTH, but are they measuring 1 to 84 PTH? Are they measuring 1 to 34? What exactly are they? And before you answer that, it would be unloyal to our friendship if I didn't express some concern about something. And I want to go to the one comparison of cardiovascular events between Romo and teriparatide in the, quote, real world. Because in the real world, physicians are told not to give Romo to people who have cardiovascular risk factors or a recent MI. There is no such stipulation about the use of Tymlos or Forteo. And so it may be that this fewer cardiovascular events simply reflects the fact that physicians have chosen not to give Romo to people who might be cardiovascularly at risk.
So thank you, Bob. I agree and take your point. If you didn't have a comment in the way of constructive criticism, you wouldn't have done your job. So thank you for that point. I totally agree. And the other point, the earlier point, I agree completely. This should be easy to do. We are technologically proficient in being able to pick up these degraded peptides. It's so simple, and yet nobody's doing it.
So before we go on, Bob Marcus was my mentor and taught me everything I know, but please keep your questions and comments shorter than Bob's, or we're never going to get through everybody's. And I'm going to go back and forth, and don't leave after the session. Right before the break, we have a big main event. We're presenting an award, so I want you guys to be here for that. So don't scoot out until after that award's presented. And I'm going to be quick with the remote questions. They're all over the place. You guys have seen them come up, but Angela Roy has a really good question about treating off-label, so to speak, with our anabolics for fracture healing. She sees a lot of foot and ankle surgeons doing this. But John, could you comment on that for us?
Well, yeah, thanks, Lynn. I'm not going to comment on that because Joe Lane and Emily Stein, who are with you, they're going to give a very, I can't wait to hear them. They're going to talk about how one optimizes the skeleton prior to surgery. And so I will delay my response to hear what they have to say.
Perfect. And there's a lot of questions about going back and forth between Romo and DMAB and the other anabolics that I might defer to because Benta and others are going to talk about that. So let's take one in person and then we'll go back to our remote. And please introduce yourself.
Hi, thank you for that talk. My name is Neera Medici. I'm an endocrinologist at Albany Medical Center in Albany, New York. I have two very quick questions. One, if you have a patient who is on Evenity and they miss a dose, how long is too long for them to miss a dose? Because with the Prolia data we have, if they miss it for 3 to 18 months, they're at really high risk 3 to 18 months after their missed dose of Prolia. Is there similar data for Evenity, romosozumab?
Yeah, before you get to the second question, I can't answer that question. I don't know. Somebody might know about the tolerance over a period of time if you miss a dose of Evenity. There are experts in the room who can speak to if you miss one dose. I don't think that would be an issue, but I don't know when you get into trouble, that is with the reversibility of romosozumab. So I'm sorry, I don't know what that tolerance is.
That's okay. And the second question is to do with the turnover markers. So with CTX, is there a certain decrease in CTX you're looking for, like a 30% decrease from baseline after starting romosozumab? After you stop it, is there a certain increase that would make you worried and want to put them on something else?
Well, yes. I mean, Romo is like virtually all the other drugs we have for osteoporosis, except for the bisphosphonates. You can't stop romosozumab without a plan for transition, because it's just like the other drugs. There is a reversibility, so you have to have a plan after that 1 year of Romo to sequence, and most likely the sequence will be with an anti-resorptive.
Yeah, no, sorry, I didn't answer the question properly. So they've done all of that and now they're on a drug holiday. Is there an elevation in the CTX that would make you want to put them back on something?
I guess I'm not following you. You've done that. What do you mean?
So sorry, they've done the romosozumab, the denosumab, and then reclassed, and now you're just monitoring their bone density every couple of years, and you're monitoring their CTX. Is there an elevation of the CTX that would make you more inclined to start them again on something, even if they're doing well clinically?
Yeah, well, this is like every patient's different. I mean, you're going to go from Romo to reclass to Romo to alendronate, Romo to DMAB. Of course, DMAB has to be transitioned too. But the bottom line is, yeah, the extent to which you're going to control bone resorption, and CTX will give you that information, it's variable. I mean, reclass can give you a prolonged reduction and maybe not. So everybody's different, but I would track this, because when the CTX starts to bump up significantly, then you begin to worry and you should probably intervene.
Like, is there a number?
Not worried. That's a good question to ask individually, because really what you're not asking is what's the threshold? So I get that. Yeah. But let's move on. And only one question. You broke the rule too. One question per speaker. Now, Irene, because you asked a great question remote, I'm going to have you hold off. Oh, he's gone. Yes, please, because you had a good question.
It's the same
remote.
question.
Okay.
So you had a slide. Hi, John, this is Irene Stanchu, Denver, Colorado. You had a slide where you put the teriparatide and there's not a limited time, which we all know about that. And then you still put at the abaloparatide 2 years. I'm a little confused about that slide.
Well, Abalo is still a 2-year drug, to my knowledge.
I thought the FDA dropped that. Am I?
Abalo? Let's.
So maybe I'm confused. So let's clarify that.
Certainly with teriparatide, it's been, I just checked on this not long ago, and I was told that there was still that 2-year limit, but I can check again.
Okay, thank you.
Thank you, Irene. So before we have another in person, Jacqueline Richard asked, any role for using TBS, trabecular bone score? Most of you know about that excellent spine bone quality test in our patients on anabolic treatment.
Yeah, there is some data, not very super secure, but as you might expect, the initial work with TBS and the anti-resorptives wasn't very impressive. In fact, not significant. But the anabolics do seem to go in the right direction. That is, go up. But as we know, TBS is I love TBS, but it's crude and semi-quantitative. You're really talking about tertiles. So you're not going to expect huge changes, although you would expect a trend upward in those who are responding to an anabolic.
Great, thank you. And this microphone, because they've been here longer than used to. Go ahead, please introduce yourself.
Hi, I'm Sonali Kachikian. I'm an endocrinologist, and I think my question kind of follows up on that. In the real world, if you are teaching, or if you're treating somebody who is high risk or very high risk with romosozumab, and then you get a repeat bone density after a year, sometimes I've done it and I don't see an improvement in their TBS, even like a bump up. Sometimes I just see an improvement in their overall bone mineral density. How do you know if they benefited, if they haven't benefited? And then sometimes you will continue treatment as you should, and then I'll see an improvement in 2 years. Is that?
Yeah. Yeah, no, we've all seen that, and I guess the message is don't fret, don't worry. Not everybody behaves like the textbooks. And again, to go back to TBS, I use TBS all the time. I'm not against it, but I don't. If it's a little bit, not behaving the way I would expect, and as you said, the next year it showed a difference. I would not panic.
And Stu, you want to
Yeah,
introduce yourself,
John,
please?
question.
Stu, can you introduce yourself, please?
Okay, Stu Silverman, rheumatologist. The question,
Stu.
John, is in my patients who are still at high risk after their two or longer years of teriparatide, we talked earlier about taking a holiday and maybe possibly restarting. But the bigger question I get from my patients is when can I now, after finishing my 2 years teriparatide, start Romo? How much holiday is needed? I don't know that. Or is there a holiday needed?
Yeah, Stu, thank you. Good to hear your voice. Sorry, I can't shake your hand. Yeah, I don't know. The Forteo, you don't want to, there's no holiday, you can't just stop Forteo. Going from Forteo to Romo, I don't know we have much information about that. But I don't know. Can't
Okay.
answer.
So we have time for about 5 more questions. So I'm going to do 2 remote and then we'll go to the microphone. Seth Cantor asks about biosimilar teriparatide or Forteo. And then unrelated to that, Amy Shaw asked, but this is 2 questions for you, John, that the P1NP curve shows that it returns to baseline in 8 to 9 months. Why are we giving Romo more than 8 to 9 months? So 2 different questions.
Well, the first question is, why are we giving Romo more than 8 months if those markers have already come down to baseline by 8 months? If that's the question, well, everybody's different. And I think if we start saying, an 8-month treatment, the data are sufficiently secure in my head that I would think on average a 1-year course is appropriate. So to fine tune this a little bit more than that, I think is probably not necessary. Now, the biosimilars, are you referring, there are a lot of PTHs now, a lot of generic PTHs. I have a patient, she emailed me again this morning. I moved her from one form to another, and she said she's getting tiny little red marks on her skin. And she's sure that she's getting a reaction to this biosimilar. She wants another one. So I don't know what to say. They're probably similar, truly, and I don't see that there's a huge difference between them.
Thank you. Go ahead, microphone.
Yeah, thank you. Tom Olenjinsky. I'm a rheumatologist from Geisinger. I just want to go back to the romosozumab and the cardiovascular risk issue. So we have a study, Romo and alendronate, Romo and placebo. We have some other studies in the development of romosozumab and a meta-analysis. Now, if I look at all of those, in general, my sense is, while that one study suggests there's a risk, others don't. Now, I also remember a drug called Vioxx, and in rheumatologist memory, that was a big drug that got pulled off the market for a big cardiovascular risk that was seen really in a polyp study 2 years later. I guess what's a better, is there any sense that bisphosphonates can reduce cardiovascular risk? And does that have anything to do with the disparate studies that we know of?
Yeah, well, thank you. That's a very good question, and it comes up as a way of explaining these 2 different results. And those of us who go back to the beginning of the bisphosphonates, which takes us to the mid-90s, Graham Russell had a hypothesis that alendronate was preventing coronary deposition of calcium. And for a while, there was a thought because the bisphosphonates initially were used in the engineering and plumbing world to prevent calcifications in pipes. This goes back to the late 1800s. So it is interesting that this difference in the head-to-head trial doesn't reflect something about alendronate. And that is where we are. It may, and it would be a way of explaining it, but I don't think anybody can be sure. And, you know, safety first, you have to be sure that you're not, you know, hurting somebody, do no harm. So although I like your thought, you still have to be cautious.
We have time. We have time for 2 more questions. So I'm going to do one remote and then Art. I apologize. So Sylvia Vella was one of the first questions. It's a difficult one, John, and it's really what is the data on numbers needed to treat for teriparatide and abaloparatide and maybe romosozumab as well, our anabolics?
You know, I don't have that information. Maybe Bob Marcus has it. I don't know.
Okay, not now. Thank you. All right, Art, please introduce yourself.
Art Santora, endocrinologist. John, I love the talk. I hope I'm going to keep my questions simple and maybe, because I know you can answer based on data. So you clearly outlined that the safety concern of PTH 1 to 34 and abaloparatide is probably, you know, no longer as concerning as it once was years ago. Black box warning is gone. Let me ask about efficacy. So what data support the use of Forteo for more than 18 months or abaloparatide for more than 18 months before switching to an anti-resorptive?
Yeah, there's very little data, Art. Bob Lindsay and I and David Dempster and Felicia years ago, we were using teriparatide in a research setting. We used it continuously for up to 4 years. And very interesting, what we saw was the bone density. Of course, you get the big effect over several years and then you plateau. The other thing we saw, as I alluded to earlier, if you use these anabolics enough, long enough, the body is going to control the anabolic effect, and the bone markers, as a sign of that, will get back to baseline. So I agree with you, Art. I don't think there isn't very much data on efficacy after the periods that the drug has been studied, but I would expect that these drugs are not going to be indefinitely anabolic.
Thank you. I think we're finished with questions. It's after 10 and